He completed MBBS from Pandit Ravi Shankar Shukla University, Raipur, Masters of Surgery and Plastic Surgery from MCH Plastic Surgery from Punjab. Lip augmentation, vaso liposuction and mesolipolysis. And over to you, Dr. Murarka, the stage is all yours.
Good afternoon, everybody. At the outset, I'll like to thank Dr. Mukesh Aggarwal, who is a good friend, for inviting me for this conference, this prestigious Ayurvedic conference. And I'm really thankful to him, and I'm really thankful to be part of this conference. I'll be speaking on techniques of hair transplantation and role of PRP in hair growth. Hair transplant, as you know, is increasing in demand day by day, and is one of the most rapidly evolving procedures of cosmetic surgery. It's not that there was not baldness or there was not loss of hairs in olden era or 10 years, 20 years down the line. Yeah, but what we are saying nowadays that as young as 20, 22 years, boys or girls, they are having hair falls, maybe because of different factors which are beyond their control. And that is why this procedure is in demand in a big way. So we should be learning about this procedure. We all have hair falls, but when do we call it abnormal? When we have more than 100 hairs falling every day, then that is called abnormal. Otherwise, it's within the normal limits. Then what is the principle of hair transplantation? What we say is, if we see a case of alopecia or a case of male pattern baldness or androgenic alopecia, what we see is mainly in the frontal area, or it involves the vertex of the head or the scalp. Reason, because these are the areas which are affected by dihydrotestosterone or the male hormones. These are the areas which are affected. Whereas even in this advanced stage of baldness, we see that the hairs of the occipital area, they are there because those hairs are not affected by DHT or dihydrotestosterone. And this is the donor area from where we take hairs and then we transplant it to the frontal area. And the advantage is, even if we are taking it from the back and bringing it to the frontal area where there is an effect of DHT, these are not affected. It means these are permanent hairs. Okay, and that is known as the donor dominance, and that is how the hair transplant works. Otherwise, if we transplant into the area where there is an effect of the hormone and it gets affected by the hormone, these hairs will go. So that doesn't happen. They behave like the hairs of the back, and this is how our transplant works. Hair transplantation is an OPD procedure. It's done under local anesthesia, and there is no hospital admission required in these cases. Now we come to the methods. What are the methods? There are different methods which are there. I'll talk about methods which are more popular nowadays, but I'll talk something about the history part or the older methods, and which are mainly plastic surgical procedures like flaps, and those can be advancement or rotational flaps or the free flaps. There are different indications for that, but this is not the forum to talk about those, so I'll be talking mainly about the free autographs where we discuss the modern methods of hair transplantation. But I'll show a few pictures where these free autografts method or the FUT or FUE doesn't work. And then we have other methods like surgical excision. What we do is, in this case is, there is an area of alopecia, and in this we reduce by excising the part of it in a serial way, so that we reduce and ultimately the hair bearing scalp comes closer, and that is how the hairs are restored. And then there's one more method which is still being used and is purely cosmetic, purely plastic surgical procedure, is a tissue expansion. I'll show you an example of that. Okay, and if we see the first slide, these are the flaps taken from the side of the skull, and one of the important or popular flap, used to be popular, nowadays it's not that popular, is Zuri flap. And if you see the second slide or second picture, that is how, I mean, the Zuri flaps are used for restoration of hairs in this young gentleman, and looks quite good. Disadvantages are that we get a lot of scarring, especially from on the side of the skull and even in the frontal area, where, but in this case it's not visual because it's been covered by the hairs. And then the third picture shows how we reduce the area of alopecia. And in the lower 4 slides, this is the example where we are using tissue expansion. Reason why can't we do hair transplant in these cases? Because there is hardly any subcutaneous tissue between the bone and the skin. You have to have some padding between the skin and the bone, and this skin looks absolutely scarred. And if you do hair transplant by normal methods or like FUT or FUE, it will not work. Reason being, these are relatively avascular area and we can't give density in these cases. So in this case, we have to expand the a part of the scalp which is hair bearing and then advance it. And this is how the result you can see in the 4th picture and the lower 4th, I mean the last of the 4 pictures in the lower part. Then comes the free autografts, and there are different ways to do it. Follicular unit transplantation, which is still the gold standard, and here we take strip of skin along with the hairs. And then one of the more popular methods and more commonly used nowadays is follicular unit extraction, and which is now named as or renamed as follicular unit excision by International Society of Hair Restoration Surgeons. And then direct hair transplantation, where we take out harvest follicles and we directly put into the slits made, and that is why they are outside, the hairs are outside the body for very less time, and people claim that the results are better. But and if we are not keeping the hair like follicles for a longer time, for more than 2 to 4 hours or maybe 6 hours, the results are almost the same. Then we have robotic hair transplantation. I mean, it's been there for quite some few years now, but this is a very expensive procedure and results are not out of the world. So this has not become very popular. And in the last, the hair cloning. Hair cloning is still in the experimental stage, where I mean, if the donor area is very less, we clone the hairs, and so that the number of hairs can be increased. But this is still in the experimental stage and is not being used. Then we come to follicular unit extraction, and what are the indications? I mean, it can be done practically in all cases, except there are a few contraindications. I mean, usually the strip excision depends on the laxity in the occipital area. The skin is very tense or very tight, we can't take out the strip. And if we take out the strip, it's very difficult to close. And if we close with the tension, the scar will be bad. So these are the cases which we should be judging the elasticity of the scalp on the occipital area, and if it is elastic, then only we should take out the strip. Otherwise, we should look for other methods. And other contraindications can be connected to tissue disorders, or if we have if the occipital area is scarred, where we can't take it. So these are the contraindications. And what are the steps? And first we mark the strip. I'll show you how we do it. And then anesthetize it by the local anesthesia, and then inflate by tumescent fluid. And after that we harvest the strip. And once we have harvested the strip, we do the slabbing, making thin slices, and then we separate the follicles. And once the follicles are separated, then we come to the recipient area. There we make the slits, and once the slits are made, and then we place the grafts into the slits. This is how the strip is marked in cases of follicular unit transplantation cases. Length and width of strip is decided by the number of grafts or number of the follicles needed. Width may also be decided by the elasticity in the occipital area, because if it is not too elastic, we can't take it broader. Length depends on the number of grafts required. Usually we take about 1 to 1.5 centimeter width, especially in the mid part, and gradually once we go laterally or the outside, it becomes narrower. And it can be up to 22-23 centimeters long, and width can be up to 1.5 or 2 centimeters, and depending on the elasticity in the scalp area of the occipital scalp. Once we have marked, then we anesthetize. And what local anesthesia we use? We use long-acting local anesthetic. Reason being, once we have taken strip, and that is taken usually with the patient in the prone position. But once we have sutured it, the patient lies on the supine position on the hair, on the suture line. And if we have not used a long-acting one, there will be pain. So we use long-acting local anesthetic, and that is 5% ropivacaine. It's not 0.5, it's 0.5% ropivacaine along with the xylocaine, and we add 10 milligram of triamcinolone or steroid and 0.5 ml of adrenaline. This is what we use for local anesthesia. And once we have anesthetized, to inflate that area, the tumescent solution is made up of 200 ml saline plus 0.5 ml of adrenaline. And we cut parallel to the direction of the hairs. If we cut perpendicular to the skin, we might injure the follicles. We have to cut parallel to the direction of the follicles by seeing it so that we don't injure the follicles. I'll show you a video where we are how the direction of knife is placed. And then what we do is we just cut the dermis and epidermis, and after that we can separate it by pulling with the skin hooks. Like if you see the second picture, it's pulling. And once you have pulled it, you can see the direction of the hairs, and then on under vision you can cut the fatty area. Or this can also be done by using opening of the scissors in the first slide, and then we lift it. What should be the depth of strip? It should be just below the roots, very little amount of fat underneath that, and it should be superficial to the vessels and nerves. So that once we remove the strip, there should not be any injury to the nerves, and there should not be any numbness in the post-op period, especially in the vertex area. And you just notice the direction of the or the angle of the knife. It is parallel to the direction of the hair, so that it is not injuring any follicles. That was the lower incision, and now we are lifting it. And the picture, which is a still picture, you can see the vessels are underneath. I mean, we are lifting superficial to the vessels and nerves so that we are not injuring it. And this is how we harvest the strip. And once we have harvested, after hemostasis, we close in 2 layers. And one of the important point is, if we just close it normally, usually we get a linear scar where there is no hairs. So what we do is we use trichophytic closure. Trichophytic closure is the way of closing it, where we are cutting one edge of the incision. If you see the first picture, and there's a line, we cut that area, and so that we get that situation in the second picture, and then we close it. So in this case, what happens? The upper flap comes on the lower part, and through the scar we can get a few hairs coming up. So the scar is not absolutely hairless. We get few hairs there also. So this is a better way to do it. And this is how we do trichophytic closure. And this is how it looks after we have done the closure, and this is how the dressing is done. And the third picture shows just before the removal of stitches. The wound is absolutely healed. And the last picture shows the scar, which is few months down the line. There's a minimal scarring. I mean, people say that FUT gives a lot of scarring and you get area of alopecia and other things. I mean, if you close it properly, usually there's not much of scarring, and the scar is hardly visible. Then we come, once we have harvested our strip, the strip should be cooled, I mean, should be put in cold saline or ringer lactate. Nowadays we have started using PRP, we are dipping into PRP so that telogen effluent is less and results are better. And as I said before, chilling ensures survival at 6 hours. So our graft survival rates are better if we have used cooled, like if we keep this like harvested strip in the and the follicles in the cold saline or the ringer lactate. And once we have harvested the strip, then we do the slavering, and this is how we do the slavering. If you see, this is done under magnification. And then we separate the follicles like this. We remove extra fat so that there's not much of soft tissue around the follicles. I mean, there's just enough soft tissue, and so that the grafts are not very bulky. And this is how it looks after removal. And this, and as I said, the strip slavering is done under magnification. And the graft dissection also, and the follicle dissection is done under magnification. About 10 to 15 times dissection is, magnification is being used. And this is how the follicles look just ready for implantation. And the upper one, the second slide, second picture shows follicles with single hairs, and these are used for making anterior hairlines because that gives natural appearance, whereas if we go posteriorly, we can use follicles with the 2 hairs, or on the more posterior part, we can use follicles with 3 hairs. We don't use more than 3, the reason being it doesn't give natural appearance. So this is how it looks after the follicles being prepared properly. And then once we have done with the donor area, then we come to the recipient area. And then one of the most important point is how do you mark the anterior hairline. Hairline is important, reason being it separates the face from the scalp. So hairline should be marked with discussion with the patients that this is how we'll mark. And we need to take his opinion. Usually we mark a point around glabella or between the 2 eyebrows, and from there it's about 7 to 9 centimeters, and that is in discussion. That is in discussion with the patient. And we should always consider the age of patient. Most of the patients will have unrealistic expectation. Doctor sahab, mera hairline yahan pe kar do. That doesn't work. Reason being, if you put more hairs in the anterior area and the lower area, you don't have follicles for the back area, which may be a large area to be grafted. So we should explain them properly. The way we make the slits, and this is how we graft it, and this is how it looked immediately after placement of the follicles. And then what are the complications? Any surgery has complications like bleeding, infection, scarring. If we don't do it properly, there can be infection, and if we don't close it properly, and if we close it under tension, there can be scarring. And it has to be planned properly, otherwise there can be rejection of drugs, or there can be poor density also. FUE, this is one of the latest methods and is being used more commonly nowadays, and these are the instruments which are needed for that, and mainly the micromotor and the micro punches, and this is how it looks. And these are the micro punches. Usually we use 0.8 or 0.9 mm punches. And magnification is very important, usually about 3.5x magnification, because we can do a better job with magnification. And this is the anatomy of hair follicle. Reason for this is what are the areas where the graft is stuck, and it's this skin and the subcutaneous tissue, and then there are lateral extensions like sebaceous gland and erector pylori muscle. So our depth of insertion should be just proximal to the bulb of follicle, and then we can pull it with just a gentle pull. If you don't do, and this is how we gauge the depth of the follicle. We can't take graft from all the areas in the back. There are safe areas which are not affected by hormones, and I'll show you that this is the safe area, and that is the center part of it. And this is how we take FUE graft, and the punch should be placed parallel or according to the direction of follicle. Otherwise, there will be transaction. And this is once we have done that, and this is how we separate or remove the follicles. And this is how it looks after placement. And this is 3 days once the patient comes for cleaning. This is how it looks. And the complications, if you don't do it properly, the punches, if you don't insert it properly, there can be transection. If we remove quite a lot, there can be thinning in the donor area. There can be necrosis of the skin also if we do remove too close, the follicles are too close, there can be necrosis. And if we don't follow the safe zone area, the longevity is not good. Then if we need a lot of follicles, we can combine FUT and FUE. Safe zone width is about 7 centimeters. If you are taking strip, we take just 2 centimeters. The 5 centimeter width is still there. So we can combine FUT and FUE both, and then we can harvest up to 5,000 follicles, and that is quite a lot. And if we we don't have sufficient follicles in the scalp, we can go to the beard, and we can go to the chest also. And these are the few pre and post-op pictures showing good results. And this is one of the cases where we have reconstructed the beard also, doing hair transplantation. Then we come to PRP. PRP is kind of wonder procedure where we take blood from the patient, we centrifuge it. There are different ways to do it. There are single spin or a double spin. And once we have spun it, and if you see the test tube, the upper part is plasma, and the lower part is blood, and in between area is the platelet. It is that is buffy coat, and that is rich in platelet. And normally, when we call it PRP, it should be at least 4 to 6 times count should be more than normal. Otherwise, it doesn't work. And how does it work? It secretes a lot of growth hormones, and there are so many, and that is how it helps. And what are the effects of PRP? It awakens the dormant hair follicles, and it improves the efficiency of follicular formation, and there is a significant clinical improvement in mean hair counts and mean hair thickness. And what is the treatment protocol? Usually we do monthly for 3 months, and after that every 3 months for first year. So altogether 6 treatment sessions in the first year. We can always repeat it in other years also. And this is how it looks. And mainly, it's a very useful procedure, especially in cases of females where there is generalized thinning of density. And the PRP is one of the very good procedures to do it. Thank you.